Hello and welcome to the September 2014 Pectus webinar. Tonight's special guest presenter is Dr. David Notrica, a Pectus surgeon out of Phoenix, Arizona. Dr. David Notrica is a native of Atlanta, Georgia. He graduated cum laude from Duke University in 1988 and Emory University School of Medicine in 1992, where he was class president and a member of the Alpha Omega Alpha National Medical Honor Society. He completed his general surgery residency training at Emory University Affiliated Hospitals in 1997 and his pediatric surgery fellowship training at Baylor College of Medicine / Texas Children's Hospital in Houston in 1999. Dr. Notrica is a fellow of the American College of Surgeons and a fellow of the American Academy of Pediatrics. He is board certified in both pediatric surgery and general surgery by the American Board of Surgery. Additionally, he is an associate professor at the University of Arizona College of Medicine, Phoenix, and assistant professor of surgery at Mayo Clinic Medical School. He enjoys training general surgery residents from the Mayo Clinic, Phoenix Integrated Surgical Residency, and St. Joseph's Hospital / Creighton Residency. He has served as a mentor for several University of Arizona College of Medicine medical students with interest in surgery as a career. Dr. Notrica was chairman of surgery at Phoenix Children's Hospital before becoming chief of staff in 2006. He has given presentations at the American Pediatric Surgical Association, Canadian Association of Pediatric Surgeons, and has been invited discussant at the American Association for Surgery of Trauma and American College of Surgeons. Locally, he has lectured at surgical grand rounds at Mayo Clinic, Banner Good Samaritan, Maricopa Medical Center, as well as John C. Lincoln Hospital. Dr. Notrica has been identified multiple times as a top doc by Phoenix Magazine Best Doctors and is listed in the top 1% of pediatric surgeons by U.S. News and World Reports and was named a healthcare hero by the Phoenix Business Journal in 2014. Dr. Notrica developed and continues to direct the Level 1 Trauma Center for Phoenix Children's Hospital. This program is the only ACS-verified Level 1 pediatric trauma center in the state of Arizona. Additionally, he is co-director of the Joint Chest Wall Program with Phoenix Children's Hospital and Mayo Clinic, Arizona. He is a member of multiple academic societies including the American Pediatric Surgical Association, the American Academy of Pediatrics, the American College of Surgeons, the American Association for the Surgery of Trauma, and Endoscopic Surgeons, Alpha Omega Alpha National Medical Honor Society, and the Michael E. DeBakey Society. Dr. Notrica lives in Phoenix with his wife Michelle and son Michael. In his spare time, he enjoys hiking, fly fishing, and running. His special interests are in biliary atresia, diaphragm pacers, inflammatory bowel disease, and pectus excavatum repair. Due to some technical difficulties, the webinar will begin about 1 minute into his presentation.
A concavity to his chest. And then here's a picture of him post-repair. So initially, we knew that we could surgically repair these patients, and we did it using a technique called the Ravitch technique. And Dr. Ravitch was brilliant. He figured out ways that we could do this operation. And I'm going to just set a little clock here. There we go. So he figured out ways that we could do this operation, and what he did was he very ingeniously removed the cartilage portion of the ribs, but left the perichondrium. And the perichondrium is the lining, the outer lining of the ribs. And what he figured out is that if you leave that lining, that the ribs would regrow, and that was the basis of the Ravitch procedure. So the procedure involves a transverse, kind of across the chest incision. We raise skin flaps, so we kind of lift everything up so we have a good exposure of the chest wall, and then the pec muscles are lifted to the sides, and basically we take out the ribs that we need to take out. Here's kind of a nice diagram of what it looks like, showing that the perichondrium, that kind of parchment-like outer covering, is being lifted up. The cartilages are being removed. We detach the xiphoid, and then we do something where we actually cut the bone. We cut the breastbone, we wedge it out, and then we put the sternum, the breastbone, into the position we want it to be in. And then we kind of leave it fairly unsupported. So here's a picture. I hope everybody's okay with this. This is a picture of an open pectus surgery. After we're done, we close the sheaths back and we put everything back the way that we found it. And here's an example of an open repair, and it's pretty good. I apologize for the graininess of the picture on the left. It was a scanned-in photo, and then there's a picture of the patient afterwards. And the results good. There are patients who have better results than this that we did back when we were doing this operation, but we felt that we could get better results. And then Dr. Nuss really revolutionized the way that we take care of pectus. And Dr. Nuss was at the Children's Hospital of the King's Daughter in Norfolk, Virginia, and he started taking out less of the cartilage and putting the bars in as the actual supports. So initially we put bars in just to kind of hold the repair in place after doing the ravage procedure, and he started doing less and less of the ravage procedure and developed what we now know as the Nuss procedure, or the minimally invasive repair of pectus excavatum. And the bars were put in. He left them in for about 2 years initially, and then took them out. And and he reported his series in 1998 at the American Pediatric Surgery Association meeting. And that meeting was, I was in training at the time, and that procedure was the talk of the meeting. Everybody talked about it, and part of the reason that everybody talked about it was that we kind of knew that there was something about the ravage procedure that we didn't like. That it was it was very different than all the other operations, and very different than most operations on bone and cartilage. You don't normally take out the bone and cartilage and have it grow back. You usually would mold it into the position. There are lots of examples in orthopedic surgery, and there's just nothing comparable to it. And the Nuss procedure really seemed to follow a lot more of the orthopedic principles, and so that's what made it more popular. The Nuss procedure basically involves taking an aluminum template, bending it to the shape, and then making a bar that fits the shape in order to correct it. And the bar is then rotated 180 degrees. And so if you can tell in this picture, the bar is kind of upside down. This is an older picture. And what we're doing here is we're getting ready to flip the bar, and the bar is weaved underneath the sternum. When we flip it, it pushes the chest wall out. Chest wall stabilizers are used in a lot of places. Of course, we don't use stabilized bars at all in Phoenix, and we wrote up our series basically showing that if you attach the bars to the chest wall, the rate of the bars coming out of position is only about 1 or 2%, and which is a lot better than with the stabilizer bars, and you don't have the extra metal. At the end of the procedure, the extra air is evacuated from the chest, and then we get an x-ray to make sure the bars are in good position. This is a picture of what it looks like. The top of the photo is the sternum, and here's a bar going across, and we've basically lifted the sternum up. This is a video, but I don't think it's going to play for us, just showing the bar rotation, and I can show that to you later as a separate video. Here's an example of a patient who's undergone a repair. Luckily, his skin is a little bit shiny, so you can see how deep his pectus is, and here he is after repair. That patient that I showed you at the beginning of the course, same thing. This is a patient that we did as one of the first patients that we did. We used to make the incisions very far back on the chest. Now they're a lot further forward. The bars are a lot shorter than we used to put them. But the results are good. And here's some other examples of children that we've done. And we can do even the very severe pectuses, you can tell, are pretty well corrected. This was a very asymmetric pectus. It was one of the first truly asymmetric pectuses that we did, and he did really nicely, with a nice even symmetric result. So defining results is difficult, and the folks at Norfolk really kind of defined it for us. And they said an excellent repair is when you have total repair of the pectus and resolution of symptoms. A good result is when you have marked improvement of the chest wall, but it's not totally normal, and resolution of symptoms. And then a fair result is if you had a mild residual pectus excavatum. or if you didn't have complete resolution of the symptoms. And this was from the early study reported by Nuss himself. And I think that this is important to understand why we do what we do. He did a lot of kids at a very young age, and this shows the percentage of excellent, good, and fair results by age group. And now, keep in mind, this is the original series, and the results are a lot better now. But what he found is that the kids that were less than 6 years of age, there were a lot of excellent and good results, but you've also got a fair number of failed procedures, almost 15% failed, and 10% with fair results. And that is really what led us to move to not do the 6-year-olds. And so in the next group, you see that you've got 6 to 12-year-olds, and the number of patients who are fair or failed is very, very small. And then you move into the older group, the 13 to 17, and it looks pretty similar, certainly no better than the 6 to 12-year-old age range. And then you get into the 18 and above age range, and then you're starting to pick up more of these good and fair results. Again, they're starting to outweigh the excellent results. So, this data I think is very, very important, because what we learned from this is we probably shouldn't do kids that are less than 6. The other thing that it taught us is that the kids that are, or the grown-ups that are 18 and older that we do this, probably shouldn't be done the exact same way that we do the kids. It doesn't mean that they're not candidates for the Nuss procedure, but the Nuss procedure as originally described, which was 1 bar and no attachment of the bar to the ribs, really wasn't going to do it for the older kids. So the results were good. What we saw is that we get a little bit of improvement in lung function. These are a lot of very technical data that we spend a lot of time talking about with doctors. But basically, the FEV1 is how much air you can squeeze out in 1 second, and these are presented in percent predicted. So instead of being able to squeeze out 100%, you can squeeze out 84%, and definitely good results. I don't think the lung function for most people is really what gives them the improvement after the operation. I think the better data really is this cardiopulmonary effect. And so what you see is that, and this is data that was reported in Pediatric Surgery International in 2007. The stroke volume, which is the amount that you can squeeze out of your heart with each squeeze, was increased by 22%, and the cardiac output, the ability of the heart to really increase the amount of blood that it's pumping, was increased by 15%, and of course the cardiac index, it went up as well, although not quite as statistically significant. And there's some things that you need to understand about cardiac physiology. Young children increase their cardiac output by their heart beating faster. So if they need more cardiac output, they simply raise their heart rate. As they get older, they raise their cardiac output in 2 ways. Their heart beats faster, but not as fast. But their heart also is able to dilate and squeeze more, and that's what we call the stroke volume. So they're actually getting more out per squeeze, and that's why we think that the pectus excavatum patients have problems when they exercise. They're fine when they're at rest, but when they exercise and they go to try and increase the volume, they're constricted by the sternum. So, and it's not like this is new data. This is data that in a lot of ways was kind of lost. So in 1972, in the New England Journal of Medicine, they did an amazing study. They did cardiac catheterizations with the patient laying flat and sitting upright. And most cardiac caths are done with the patients laying flat. And if you've got a dent in your chest that's pushing in, when you lay flat, the heart falls away from that dent. And they realized that, and that's why they cathed them both supine, both laying flat and upright. They did 6 patients, and they measured the cardiac output during intense upright exercise. And it was low in 2 of the patients, and at the lower limit normal in 1, and then low normal in 2 more. And then after operation in 3 patients, they had during intense exercise, they had an average increase of 38% in their ability to 38% increase in their cardiac output. And the conclusion is that pectus excavatum can in fact reduce the pumping capacity of the heart during upright exercise. Well, it turns out when we exercise, we are upright. And that is the time that we need to be able to increase our cardiac output. So that New England Journal of Medicine paper from 1972 really told us everything we needed to know. But then we went another 30 years just basically ignoring it. I'm going to skip over some of this because I do want to have a fair amount of time for questions when we're done. Basically, a meta-analysis looked at 8 studies, and basically the percentage improvement for cardiac output ranged between 6% and 31%. And there's an exceptionally large effect size in patients with severe pectus. So really, the more severe your pectus, the more physiologic impact it's going to have. And this is always a bit of a problem for us because we'll have some pectuses that are very, very mild, and they're not compressing the heart, and visually those are problematic, but those are the ones where you're going to get a 6% increase in cardiac output, and the more severe ones are the ones where they're really going to get much better improvement of their symptoms. So we'll talk about that at the end when we talk about correction index versus the pectus index or Haller index. So the feeling from a lot of these researchers is that the pectus excavatum significantly improved the cardiac function, and it really contradicted the argument that went on from the 1980s until 2000 about whether or not pectus excavatum was physiologic or cosmetic. And the answer was clearly, for these patients who have cardiac compression, it is physiologic, no question. This is a very complex slide, and I'll tell you that this is a CPET slide. So CPET is cardiopulmonary exercise testing. And what's supposed to happen when you exercise is that you should be able to increase your cardiac output, and that's demonstrated here by the VO2, and that's VO2 per heart rate. And what you see in this patient who has a severe pectus is that this line is flat. They are not able to improve their cardiac output as the exercise progresses. Here is the same patient post repair, and you see that now they're able to increase their cardiac output. And so as their heart rate goes up, their cardiac output is going up, and it's output per beat. So this is divided by heart rate. So this is a much more normal physiologic response. So this is the often talked about Haller index. It's a ratio of the width of the patient divided by the front-back distance. I often tell my patients that what we consider normal is if you're 2.5 times as wide as you are front to back, and that's measured internally, not externally. So that 2.5 number is a pretty good number, and it really holds up better than you'd expect in the wide range of people. It doesn't hold up for everybody, but by and large, people only vary by about 0.1 or 0.2, so 2.5 times as wide as they are front to back. As your front to back distance decreases, what happens at that point is your ratio goes up, and so whereas 2.5 is normal, once you get to about 3.2, that's considered a moderate to severe pectus. Now, there's not great data to support that. This is the Haller index is the standard of care. You will find it in every publication. You will find it in every insurance plan requirement, but there's not good data to back it up. And we'll talk a little bit about the correction index, which may end up being a better measure when we get done. The workup is basically we start with the history and physical examination, and it starts with what kind of symptoms they're having, and if the patient's not having symptoms, we don't do an extensive workup. We don't spend the money on the CT scan or the MRI of the chest and the echocardiogram and the pulmonary function test and EKGs if they really don't have symptoms. And so step one is, does the patient have symptoms? And if they do have symptoms, then at that point we do the workup. And the workup has changed over time. We used to do chest CTs on everybody, and now we're moving to MRI scans in the children because of the risk of cancer associated with the CT scans. So they all get EKGs. We're looking for problems with conduction or what they call dysrhythmias or abnormal rhythms. We're also looking for problems where the electricity isn't conducted correctly through the heart. We look at pulmonary function tests to make sure that they don't have a severe lung problem that we've missed, and make sure that kind of quantify the degree of pulmonary component to their disease. And then in patients where we're still on the fence or if we're concerned, we get cardiopulmonary exercise testing. We used to get it very rarely. Now we're getting it more commonly, mainly because the insurance companies want physiologic evidence that their particular patient has an impairment, not just that they have a severe pectus. That they want to, all right, does this particular patient have a physiologic impairment? So unfortunately, a lot of that is driven by the insurance companies. We don't know why patients get pectus. Certainly, there's an abnormal growth of the cartilage and or the ribs. And we used to tell people that it was just differential growth, that one side's growing more than the other. A nice study, it's a little bit complicated, basically showed that it's not differential growth. We do know it's associated with Marfan's syndrome and patients who have collagen vascular disease. And certainly it runs in families, so it's very common for families that have families that have one person with a pectus may have others. So I'm going to ask if you can call it. Sorry about that. The most common symptoms are shortness of breath and lack of endurance. I'd say that of the children that come to us seeking care, that is the number one reason, is that they say that they can't exercise as well as their peers. And what we generally do is we say, all right, well, are there other kids in your class that are of a similar body shape to you, and do you exercise as well as they do? And what you find is a lot of these kids do fine in sprints, but they start having trouble at distance. One of our kids was a baseball player, and he said, when we run from home to first base, I'm the fastest guy on the team. But when we run all 4 bases, I'm second to last. And I think that really defines what the physiology is of pectus. So chest pain is very common. Typically, these patients are getting chest pain at the junction of the rib and the sternum. Frequent respiratory infections we thought was a big component of it, but if you really start asking all patients, only about 4% of patients really have frequent respiratory infections as an issue. Asthma and asthma-like symptoms are very, very common, with about 34% of patients having those. When we look for indications for surgery, about 85% of the patients that we operate on have cardiac compression, either by CT or MRI or echocardiogram. Cardiac displacement is very common. Mitral valve prolapse is very common. Mitral valve prolapse is one of those problems because it's so common in the normal population that it's hard to know what the impact of pectus is. But if you actually look at the heart that's being squeezed, basically being impinged or pinched by the sternum and the spine, you can see how the valve itself actually gets bent out of shape, and then that leads to prolapse, and it leads to mitral insufficiency. Other problems such as bundle branch block, which is a conduction problem within the heart, are common, as is valve problems and hypertrophy. The established criteria for repair at this time are that you have to have symptoms. You need a pectus index of greater than 3.2. They've dropped the 5. it was just, the test just isn't that accurate. Index greater than 3.2 with either cardiac compression or pulmonary compression. Or if you have mitral valve prolapse or murmur, a conduction problem, if you have pulmonary function tests that are abnormal, or if you've had a failed previous repair. The problem with failed previous repairs is that the index really is not all that great at predicting improvement. If you've had one surgery, the second surgery, you don't have to meet the 3.2 in order to have that redone if it needs to be redone. Complications, we don't love the fact that there are complications. These are the complications first reported by the Nuss group. They had more experience than anyone else, and so they had 1,200 patients, and this was their complications. They had no deaths and no cardiac perforations. There have been numerous reports of puncturing the heart during this operation. Luckily, it's never happened to us in Phoenix. It never happened to the group in Norfolk, but it was reported. The other talk I was going to give actually goes into all the modifications of the operation, how the operation's changed since 1998, and I will tell you that what we do now to prevent that from ever happening is remarkable. Everything from putting a camera in. This operation was initially done blind. We put a camera in so we can see. We elevate the sternum, and I'll try and show you some pictures of that at the end of this talk. Our entire approach to this is just much safer. I mean, we understand that that putting a hole through the heart is just not acceptable in 2014, and we spent a lot of time and effort avoiding that complication. The other complications that were seen, a lot of them had to do with bar displacement. So I mean, here, when you take all those patients that started back in 1998, about 12% of them had a bar that flipped or rotated, and once about 8% of those had to be reoperated on. Now, prior to them using the stabilizer, it was very high, and once they had the stabilizers, they got down low, and then once they wired the stabilizers, they got down to about 2%. And then we started using fiber wire instead of the stabilizers, and we were able to get down to less than 2%, and we didn't have the extra metal of the stabilizers. And so that's what we're doing now. This complication of bar allergy, they noted that it was 3, and what we didn't realize is that there probably were a lot of people who had bar allergies that we didn't know, and these bar allergies are metal allergies. So the standard Nuss bar has a lot of components. It has nickel as the main component, molybdenum, and a bunch of other minor components to it. And nickel is a pretty common allergy. So we've actually moved to testing all of our patients for metal allergies before we do the surgery. And if they're allergic to the metals in the bar, we then order a titanium bar that's custom made from the manufacturer, and we implant that instead. Overcorrection happens sometimes. We work very hard to avoid that, but that occurred in about 5% of their patients. We're seeing that a lot less now. Here's some examples. So here on the right side, this was actually a redo pectus. So this was a pectus, a patient who had had surgery previously, and you can see kind of some wires from the previous operation. And on the sorry about that. On the X-ray, you can see that one bar is in good position, but the other bar is rotated, and that's what a bar malposition looks like. You'll notice, and this is a much older picture from our series here in Phoenix, and you'll notice that there's a stabilizer bar on that left side. We don't use stabilizer bars, so this was a patient who was sent to us, but not uncommon. We try very hard to avoid it. This was a patient of mine, and this is a patient who was a redo after a prior ravage procedure. So there's that scar in the middle is a typical ravage scar that another surgeon had done when he was quite younger. He recurred. We redid him as a Nuss, and he developed the swellings on either side. and the swelling was fluid. We drained it. It was sterile. It didn't come back. In retrospect, we now know that this is probably a bar allergy. And we were very lucky because he didn't have further problems with it. But this was back before we were testing for allergy. And I was looking back over my photos and I remembered this guy, and I immediately realized, yeah, this was our first bar allergy patient. We talked about cardiac punctures. There were 11 cardiac punctures reported in 20 years, 4 of them by pediatric surgeons. One of them was during a redo of a prior open operation. One happened during bar removal. And like I said, it's we, knock on wood, we hope to never have one of these. We spend all of our energy in making sure that doesn't happen, but there have been some good surgeons who have done it. This is a picture from that article showing the cardiac perforation, and this is, I know it's hard for people who don't look at this all the time to understand, but the heart is seen here, and these weird looking things that are pointing inward are actually ribs, but the ribs are not attached to anything, and there's a good chance that one of these ribs actually punctured the heart during this operation. So you don't typically see free-floating ribs even in the redos that we do. This was an exceptional case, but you just have to be extremely careful, and you want a team that's done a lot of these. So there are a lot of there are 3 predominant options now. There's the open ravage procedure. It has longer operative times, more blood loss, more conspicuous scar. Its advantage is that it has less pain, and the hospitalization it used to be significantly shorter. Now it's probably about the same. The minimally invasive repair of pectus, or the Nuss procedure, has a shorter OR time and less blood loss. The scars are much more subtle. It does have more pain than the ravage procedure, and really we spent about 7 years figuring out how to manage that pain. So now most of our patients are going home in 3 or 4 days. They used to be there 7 to 9 days, and that really was a concerted effort from our pain service, our pediatric pain service at Phoenix Children's Hospital, to match the pain meds to the operation. So more pain, but definitely managed much better than we did initially. And then the third option is silicone. So silicone corrects the cosmetic portion of it. It doesn't correct the physiology at all. The silicone has a high complication rate, and there's really been limited patient interest in that. Men generally just don't want silicone put on their chests. So these are some of the results showing that 69% of those had good or excellent aesthetic outcomes. So it's done, it's reported. When you look at body image, if you ask patients about how they feel about their appearance and if they're self-conscious, and whether or not they have physical symptoms of it, what they really found is that there are very significant added emotional difficulties that are associated with this defect, with pectus excavatum. It's hard to understand this. There's no good paradigm to understand why this deformity would have more of an impact on psychology than other deformities. A lot of people that I've talked with, if you think about it, when they say me or I, they'll point to their chest, and I think a lot of it has to do with feeling that their chest is really who they are. I mean, that's what they associate with self, and I think that if your self has a great big hole in it, that it's probably difficult. 97% of the patients that had surgery had improvement in how their chest looked, and 90% were happy or mostly happy that they had undergone the surgery. Before surgery, about 68% of the female patients and 40% of the male patients were bothered by their chest often or very often, and a year later those were down to 6% for the females and 4% for the males. So really pediatricians who were dismissing this as an inconsequential problem really were missing the boat, and it's not trivial in either the physiologic effect or the impact of this deformity on the child's life. I was giving a lecture to some pediatricians, and an older pediatrician came up to me. He was much older, and he actually had Parkinson's, and he told me that even at this stage of his life, if he was in better health, he would have the operation to have it fixed now, because even though he had had a full life, he felt that his pectus was an issue, even to the point that at the end of his life he would have had it fixed had he been in better health. We're going to skip a lot of this stuff. I want to talk a little bit about compressive bracing, and so people ask me, well, can you brace pectus excavatum? And the short answer is that that we have a lot of experience with bracing pectus carinatum, which is where the sternum is bowed outward, and one of the first reports was done by Craig Egan, who's with our group here in Phoenix, and he basically proved that it could be done. He used a radiopaque marker and proved that you could actually brace these kids back into normal position. And then the group at Cincinnati Children's did the first large series where they put a bunch of kids in braces and proved that those that wore the brace did get good results. They had 100 patients evaluated, 57 of them had no treatment, and 29 of them were fitted with a brace. Basically, 3 of them were non-compliant, 26% of them had good outcomes and then no complications, and about 17% of the patients, including 3 of the non-compliant patients, actually underwent surgery to have it fixed. It's an AP compression brace. That means anterior to posterior or front to back compression. It's worn over a t-shirt. The straps are tightened on a regular basis. They're followed up at 6 week, 3 month, and then twice a year thereafter intervals. And initially all these braces were custom made. Now there are off-the-shelf braces that we use for bracing, and this is a picture of some of the older ones. You can go on the internet and see pictures of the new ones that are marketed by a company that we won't talk about, but the brace is very good. At this point, I'm going to show just a couple of other things that I wanted to touch on. Pardon me one second. I'm going to grab the article showing the Pectus index. The correction index. I think that this was an amazing paper, partly because we all knew that the other index wasn't right. Somehow I'm gonna find a way to share this.
You
Screen
probably
sharing.
need to,
here we go.
Yeah, change the application to what you're sharing.
Okay, show my application. There we go. Can you see that, by the way? Is that?
Nothing yet. All I see is your.
There's
There we go. I see it
showing up
now.
at all?
Yes. Yep, that's good.
Okay.
Yeah, they're
Great.
showing up.
Thank you. So, what this is showing is the Haller index. This is a patient who has an atypical chest appearance, and so this patient's a little bit more barrel-chested than other patients. And so, if you look at the width and the AP distance, their Haller index is only 2.73. That wouldn't qualify for surgical repair by the insurance company, but you see that there is pressure on the heart. The heart is being misshaped, by the compression. If you look at the correction index, so now what we've done is we've drawn a line at the spine, and now we've measured the distance between where the sternum is and where the sternum should be. The sternum should really be the same height as the maximum portion of the rib. So basically your sternum should be the furthest part out of your chest wall. And this ratio basically is just a percentage, and it's if you were to put a bar in and correct this, what percent would it correct? And so this patient's correction index is about 22.7%. So if you were to put a bar in, you would give this patient 23% more room in their chest. And this really, I think, measures what the defect is about and what the operation is about. So I think that this is a much better index than the correction index. The only downside is it hasn't been accepted by the insurance companies yet because it's relatively new. My disclaimer on this is that Sean St. Peter, who wrote this paper, was one of my former residents, one of my former trainees, and he's had an amazingly successful career in Kansas City. He published this in 2001. Obviously, I'm proud of the fact that he did this, but I think that even if he wasn't my resident, you have to sit up and take note of this. I think it's a better way to evaluate kids with Pectus, and adults with Pectus too. So with that, I am going to stop sharing my application, and do we have time for questions, Adam?
Oh, yeah, we do. Thank you very much for that presentation. It was great. I'm going to go ahead and ask one question now that we just talked about the correction index, and that would be, if the correction index does become the gold standard for insurance companies, what would the cutoff be?
So in Sean's paper, he set the cutoff at 10%. I think that is a little bit liberal. I think that you're probably going to see a cutoff. The only other paper on correction index was in the Annals of Thoracic Surgery, and they recommended, I think, 28%. I think you're probably going to see a compromise coming down the pike of 20% as the correction index. If you can't correct the chest 20%, it probably is too much surgery to do to lift it 10%.
Would they also take into account Haller index, or they simply switch out Haller with correction?
I think what will happen, insurance companies are very slow to make changes. I think that you'll see Haller index for at least the next 10 years. Even if we had good data today, it would take 10 years to correct it. So I think that you're going to see Haller index for quite some time into the future, and hopefully we can, once we validate that the correction index correlates with physiologic impact, I think that you'll see it reported more frequently by surgeons doing the operation, and then eventually there'll be a change in what insurance companies accept. I'm currently chair of the practice committee at the American Pediatric Surgery Association, and we wrote the guidelines for Pectus carinatum. We're looking at writing the guidelines for Pectus excavatum, and I think that if we can get just one or two more papers that we can put Pectus, the correction index, in there as an alternative way to assess the patient, I think that will actually aid the adoption and maybe speed it up by 5 years.
When you read the paper, it really does seem like a no-brainer.
Yeah.
Okay, we're gonna open up to the questions from the general audience now. I do have a set of questions that I'm going to ask a few people to ask by themselves. So I see Paula is here. Paula, I hope that you are with us and attending. I will unmute your microphone so that you can ask Dr. Notrica a question or two. I'm going to unmute you right now. Paula, are you with us?
Yes.
All right, go ahead and ask Dr. Notrica your questions.
I was just wondering, I know that you guys are doing the on-cue painball study versus the old epidural. I'm wondering what your study has shown.
What it's shown is that people are on the internet and aren't signing up for the epidural, and the study is not going very well because every time somebody gets randomized to the epidural, they go on the internet and they say, no, I want the painball. So that data has been very slow coming because we're having trouble getting the comparison group. And that's a study that we're doing at Mayo, and so Don Jarzewski's heading that study. On the kids, we're not doing epidurals anymore, and so in the adults, she's still trying to randomize them because the adults potentially have more benefit from the epidurals than the kids did because they're at higher risk of having lung complications than the kids are. But it's been really hard to enroll the patients for the epidurals because Pectus patients are very smart patients, and they go on the internet and they read about it, and then they say, I don't want that.
Okay, good, fair enough. Thank you.
Thank you.
You're welcome.
All right. Now, Julie, I hope you're here. I did get an email from her that she's having trouble getting on, but it actually says that she's in the room, so I'm going to unmute her and see if she's available. Julie, are you with us?
Yes, I'm here.
Okay, great. Do you have a question?
Well, I had a question originally about complications during surgery, and you went over a lot of that. I was surprised at the high percentage of lung collapses, I guess, during surgery over that, I guess it was a 10-year period. I'm just wondering how common that is these days to have that occur during surgery.
So in the pediatric patients, that's a great question. In the pediatric patients, the number of patients, what we did, because we thought that number was unacceptable, is we started getting x-rays at the end of the surgery. And so every one of the patients that we do at Phoenix Children's, at the end of the case, before we wake the patient up, we get an x-ray and we make sure that the lung is up. And if it's not up, we put the chest tube back in, we suck it out another time, we basically suck out the carbon dioxide, because we're blowing CO2 or carbon dioxide into the chest to see. We suck it out a second time. If after the second x-ray there's still a pneumothorax, we put the tube in and we leave it. So our pneumothorax rate is very, very low, and it was just a decision that we didn't want to have that complication anymore. So that was it. Every once in a while we'll have a patient who has a small amount of retained carbon dioxide after surgery, and even if you can't see it on the x-ray, they'll tell you that they have it because they're like, oh, my shoulder hurts right here on top, doc. My ribs are fine, but my shoulder hurts, and that's CO2 that's left in. So we do everything we can to get that out because it's a big pain issue. Physiologically, it's irrelevant. Okay, it doesn't have any impact on their breathing. It doesn't make them short of breath, but that shoulder pain can be a huge issue for them.
Okay, well that's good to know. Actually, my son will be there at Phoenix Children's this coming December, so we may see you there.
Excellent.
We and actually we have gotten information about the pain ball, and I understand that that's actually put in place during the surgery.
Yeah.
When did that actually come out?
Post-op day 3. We pull it out in the morning before they go home. So post-op day 3. Some of the kids go home on day 3. Some of them go home on day 4.
Okay. Great. Thank you very much.
Thank you.
You're welcome.
Okay, I believe this next person may not be here, but I think it's a good question, so I'm going to go ahead and ask it for him.
Okay.
And that is permanent nerve damage after Nuss. Is that possible? And of course, I've had Nuss. I've got a small strip of numbness, but is it possible to have nerve damage to the point of constant pain?
Yeah, I think so. I think even in patients who undergo procedures as minor as just a chest tube can potentially get nerve pain, and so that's very real. It's not predictable as to who's gonna get it. I would say the vast majority of the patients have some strip of numbness after the Nuss procedure, and we don't know exactly why. It actually happened even before we started fixating the bars around the ribs, because the concern is that if you tie the bar in around the ribs, that maybe that's going to cause the numbness. The reality is that the way that the rib is shaped, the bottom of the rib actually has a little cove in it like this, and so the nerve runs inside that, so it should be pretty well protected. So if you put a stitch in, it's going to hit this point and that point. It shouldn't be able to get to that nerve. But definitely it is possible for that to happen. We start treating nerve pain very aggressively as soon as we have any signs that they're having what we call hyperalgesia. Hyperalgesia is when you touch the skin and it hurts. So it's not like you're pushing or pressing on them. You just lightly touch the skin and it's extreme pain. As soon as they get any signs of that, we actually start them on medications.
And the other question was, In the event of a Nuss failure, I guess due to pain or due to something like that, or a flip, would you ever recommend a ravage instead of Nuss, or is it simply, is Nuss the preferred method these days for correction?
So, so I guess the short answer is we do Nuss procedure as a primary operation. So someone who hasn't had surgery before, we do the Nuss procedure on everyone. There are some patients. Now, let me start by telling you that the redo patients, which we mainly do at Mayo, we do a few of them at Phoenix Children's, but they tend to be adults by the time they get to us for redos. Essentially, those patients get a Nuss procedure, and then if the result is incomplete, then we reopen. Then we do a ravage procedure in addition to the Nuss procedure. So we go in there and we take out small amounts of the cartilage, not big amounts. We're not doing these complete cartilage resections. We're actually cutting the cartilages enough that we can release the sternum, and then we'll cut the sternum and put it in position. The nice thing is that with the bars in place, the chest wall is completely stabilized, and so all it has to do is heal in that position, and we don't have to worry about whether or not the ribs are going to regrow in the adults, which has always been a concern. We know that something grows back. It may not always be ribs, but something grows back. But by limiting the rib resection, we leave the patient with a much more stable chest from the moment that the surgery is done, from the very end of the surgery.
Gotcha. All right, another question. Go ahead.
Oh, and then you asked about the ravage procedure. There are a few patients that we've put bars in, and especially the mixed excavatum carinatum. So the patients who have part of their chest that is protruded out and part of it that's protruded in. In the series from Korea, they put Nuss bars in everybody, and they all corrected. In a few of the patients, they have Dr. Park has. If you look at Dr. Park's patients, they don't necessarily look like my patients. He's got tons and tons of patients, and they tend to be thin and very flexible. And that's not necessarily the average American patient. And so some of the kids that we've done that have mixed defects, when we put the bars in, we have not gotten the Pectus carinatum to correct completely. And in those patients, sometimes we'll say, all right, look, if it's really bad, we're going to take out those ribs or cut the ribs and put them down. And we've had to do that a few times. We haven't done a full ravage procedure on those, but sometimes we have to do a little bit more than just the Nuss procedure, but it's the minority of patients.
Gotcha. Okay, the next question, I hope Leslie is with us. I'm going to unmute you, Leslie, and you can ask a question. Leslie, are you with us?
Oh, hi there. Yep.
Hello.
Can you hear me?
Yes.
Yeah.
Okay. I have a son that's going in for a Nuss procedure in a couple of weeks, and I wanted to know what would be the single most important question I could ask the doctor about his procedure.
How many Nuss procedures have you done?
Yes.
I mean, that's it. So the problem with this procedure, so we as surgeons do operations all the time, and we learn new operations all the time. The Nuss procedure has a learning curve that is much steeper than other operations. So a typical new operation has a learning curve, a steep learning curve of 3, and by 10, you're just not doing it any better than you did when you did 9. The Nuss procedure is at 20 and 30, you're still doing it better than you did at 19 and 29. So so experience is very important. The other thing is, if they're doing the original Nuss operation as described in 1998, then there have been too many modifications to do it the old way. There have been 57 published modifications of the operation, and they should have adopted some of them.
So what kind of adaptations would I be looking for? I know that the doctor said they do use stabilizers. I believe I thought he said he actually developed the stabilizer. I don't know what modifications specifically. I wouldn't know what I was trying to listen for.
Okay, so the folks in Norfolk still use stabilizers, and so they're very good surgeons. They've done more than anybody. They've done 1,200, counting the ones that Nuss did before he retired. And so as much as I advocate against stabilizers, there are still very good surgeons using stabilizers, and I challenged Rob Kelly to look at his results before stabilizers and after stabilizers. And he did, and it was completely unchanged, but he still uses them.
Yeah.
So, and Rob Kelly is one of those people he's an excellent surgeon and a great human being, but he won't give up his stabilizers. So it's just the way it is. He's got good results. I can't complain.
Yeah.
You can get good results with and without him.
Yeah, I was just I've been reading about the pain level. I think they say kids that have the stabilizers maybe have a little bit more pain, but it's my child. I don't want him to have any pain.
It goes away.
The pain goes away. Thanks, Adam. I will tell you that we ran the advanced Pectus course here in Phoenix in May. And one of the most popular, like we thought we were going to run it for like 15 or 20 docs, and we ended up with 50 surgeons at the course. And one of the most popular lectures at the course was given by our anesthesiologist, who talked about the way we manage pain. And there's a lot that can be done to improve it, and hopefully they will have heard about what we've done, and hopefully are doing something similar.
I think you kind of cut out there. What you said, when your anesthesiologist said when you do what?
Oh, the most popular lecture in the entire course was the one given by the anesthesiologist, who talked about managing the patient's pain. And they use a multimodal technique, and he's putting up slides, and people have their iPhones out and they're taking pictures of the slides to send back to their anesthesiologist at their institution.
All right. Thank you, Leslie.
Yep, thank you.
Okay, and now there should be a Natalie online. I do see her, and I'm going to ask Natalie to ask a question. I'm going to unmute you in just a moment. Natalie, are you with us?
I'm with you.
What's your question?
I just have a question. It seems like I have networked with a few people in the connective tissue world that had surgery. Seems like back in the 70s and maybe the early 80s, it was performed, the excavatum surgery was performed at an earlier age than it is now.
Yes.
But I'm dealing with a 2.5-year-old that has a known connective tissue disorder and has lung issues, has cardiac issues, and I was told to get a second opinion from a second surgery. And we're just kind of standing here going, do we wait until she's 9 or 10, or is there really some evidence that treating it earlier in some patients can be beneficial?
So, unfortunately, because I'm in Arizona, I can't give you specific advice about your child, but I can give you.
I understand that.
But I can give you some general advice.
Right.
Which is the Ravitch procedure, which was done previously at young ages, should never be done at a young age in a child. I mean, that's so there. That is pretty much nobody's going to argue that don't do a Ravitch in a young child.
Right.
The results, like I showed you before, are that if you do it before age 6, even the Nuss procedure before age 6, the results are not going to be as good as they are if you wait until they're a little bit older. We, myself and basically the rest of the pediatric community, had really drifted the age from 6, 7 to about 12, and so if you had asked me 3 years ago, I would have told you that the the ideal age to do it is age 12. The groups in Asia are now saying that they're actually saying, well, you know, we should reconsider this and maybe we should be doing the younger kids again. And I think they may be right. I think that somewhere between 6 and 12 may be a very acceptable age at which to do the repair. So and so the youngest child that we've done, I think we've done one 6-year-old, we've done a couple of 9-year-olds, a handful of 11-year-olds, and then really, everybody else is 12 and up. And
Okay.
so, but the results in the 9-year-olds and 11-year-olds have been phenomenal. And I don't think there's anything wrong with doing them at that age. I do think that there's a problem with doing them before age 6. So
Okay.
that's a range, and you have to individualize it for every kid. I think if you have a connective tissue disorder, if your child does that, you have to factor that in as well. The kids with connective tissue disorders are going to be a little bit more likely to recur, and
Okay.
they need multiple bars, and it's hard to get multiple bars in when you're young, and there are a lot of factors. It has to be a very individualized decision. I personally don't like my results in my kids with Marfan syndrome as much as I like my kids who don't have Marfan syndrome results. They're getting the exact same correction. Their correction indexes look great, but a lot of times their chests have irregularities to them. Their sternum's in perfect position, but their chest just isn't straight and flat. It looks kind of like the moon, and
Right.
and that's it's a source of frustration for me as a surgeon, and a little bit of a frustration for them as a patient, although most of them are okay with it. But yeah, I don't think I get as good a result in a Marfan's patient as a non-Marfan's patient. That Ravage procedure that you saw was a Marfan's patient, and he didn't get a good result with the Ravage either. So they're just a much tougher patient population.
Just when someone had previously asked a question how many cases or how many Nuss procedures have you performed, being a good interviewee question for the surgeon that you're seeing. What is a good, at what point should we as parents be comfortable that someone is competent enough and has performed this enough to do it on our children?
I think the bar should be 50, to be honest with you.
Okay. Okay.
Dr. Nuss says 75. This is Jackie. Jackie Hurley is my Pectus coordinator, and she's absolutely wonderful because families have so many questions that they think of after the doctor's visit, and
Yes.
99% of them Jackie can answer. So she's been a huge asset, and that's a typical one. Dr. Nuss says 75. I think 50 if you've had the Nuss course.
Okay. Okay. I appreciate it. Thank you very much.
You're welcome.
Thank you, Natalie. All right, I think I've got one more question for you, and then we will say goodnight to Dr. Notrica. And that question is, are there any new materials being, let me read this word for word. Are there any materials other than common nickel alloy titanium being investigated for use in the Nuss procedure, possibly a composite that has similar density and elasticity to the ribs and cartilage?
The short answer is not that I'm aware of. The problem is, the answer is that's a great question. Not that I know of currently. Ideally, we should be printing these. You have a 3D printer, and we should print them out. And we're not to that point yet. I think that we will get to that point within the next 10 years. I'm looking forward to that when I can print out the perfect bar and then implant it in the patient. But no, we're not there.
I have seen the doctor in Turkey. He's 3D printing his stabilizers, but only to test new designs.
Yeah, brilliant.
All right. Well, thank you very much, Dr. Notrica.
All right, Adam, I really appreciate it. I appreciate all you've done, and Becky, I know that you're there very quietly, and I appreciate everything that you guys did. Have a great night, okay?
Well, thank you. We will be taking more questions from the rest of the presenters on staff here. But good night, Dr. Notrica, and thank you very much. Good night, Jackie.
Thank you, Dr. Notrica. Thank you, Jackie.
Bye.